Hello everyone, I'm Dr. Monica. Today in this video, we'll be discussing about a rare but classical syndrome that is Papillon-Lefèvre syndrome. So what is Papillon-Lefèvre syndrome? So it is an autosomal recessive disorder which is caused by an mutation on the chromosome number 11q14 q21 in the CTSC gene. This encodes for the cathepsin-C enzyme, which is responsible for activating the serine protease in the immune cells responsible for proper immune function and normal epithelial integrity. So coming to the etiology of PLS, it involves three major components which include genetic, immunological and microbial. So coming to the first component, that is genetic. So PLS, it is an autosomal recessive disorder mainly caused by the CTSC gene mutation. This gene, it is highly expressed in palms, soles, knees, catenarized gingiva and immune cells such as neutrophils, macrophages and their precursors. So because of this mutation, these tissues, they will show abnormal function. Also, this condition, it is more common in consanguineous marriages. So coming to the immunological component, CTSC gene, it is responsible for activation of serine proteases in the myeloid and lymphoid cells. So its deficiency, it results in weakened immune response, which increases susceptibility to infection and also an impaired NK cell cytotoxicity. So talking about the microbial component, because neutrophils they are defective, they show reduced response to bacteria like Staphylococcus species and Aggregatibacter actinomycetum comitans. So AA it produces several virulence factors that cause rapid periodontal destruction. So patients with PLS they show high IgG titers against AA that indicates constant bacterial challenge. So coming to the oral clinical features of PLS, we can see the patient show severe gingivostomatitis, that is the gingiva it is inflamed, ulcerated and painful. There is early onset severe periodontitis which appears soon after tooth eruption and this is a key diagnostic sign of PLS. There is also rapid alveolar bone loss with deep periodontal pockets and pus discharge and the patients present with premature exfoliation. That is, deciduous teeth they are lost by 3 years and permanent teeth they are lost by 14 years. We can also find loose mobile drifting teeth with painful mastication and fetid mouth odor. There is severe alveolar ridge resorption with reduced vertical dimension and children present with denture face appearance. So coming to the cutaneous or the dermatological features, we can see that in patients of PLS, there is presence of palmoplantar hyperkeratosis in which there is thick scaly skin on the palms and soles. Next is hyperhidrosis. In this, there is excessive sweating beyond normal. Next is intracranial calcification. We can see the patient have mental retardation and there is arachnodactyly, which means that there is long, slender, spider-like fingers and toes. There is also recurrent infections due to impaired immune function. So histologically, PLS shows hyperkeratosis, acanthosis, hypergranulosis, parakeratosis, and psoriasiform hyperplasia in the gingival epithelium. In the periodontal pockets, we can see exocytosis of the inflammatory cells such as PMNs and macrophages, and we can find that there is increased vascularity with mixed inflammatory infiltrate in the connective tissue. And coming to the palmar skin, we can see that there is epidermal thickening, hypergranulosis, hyperkeratosis, and mild mononuclear infiltrate in the papillary dermis. So coming to the radiographic features, in the localized form, we can see that there is vertical alveolar bone loss around the incisors and first molars, typically near puberty. Also the bone loss, it is uneven. Coming to the generalized form, we can see in the advanced cases there is severe alveolar destruction, which gives teeth a floating in air appearance, and the unerupted teeth they usually develop normally in the crypts but may show abnormal positioning, or incomplete root formation. So the investigations required for diagnosis include hematological harmony, say height and weight gain calculation, urine analysis, alkaline phosphatase, radiological investigations which include orthopantomogram, intraoral periapical radiographs and the lateral cephalogram, neutrophil functional tests, and conventional polymerase chain reaction for microbiological analysis. So differential diagnosis includes acrodynia, hypophosphatasia, and cyclic neutropenia. So coming to the management of PLS, it is difficult due to its poor prognosis and unpredictable progression. It requires a multidisciplinary team which includes dermatologists, pediatrician, dental specialists for comprehensive care. So coming to the dental treatment, the main goal is to eliminate pathogenic bacteria to control periodontal destruction. Firstly, scaling and root planing is done, followed by oral hygiene instructions, and patient is asked to use 0.2% chlorhexidine mouthwash. Then it is followed by antibiotic therapy, that is tetracycline or erythromycin, with adjunctive systemic antibiotics, which uses amoxicillin 20 to 50 mg per kg per day with metronidazole 15 to 35 mg per kg per day, which is given in divided 8-hour doses. So talking about the prosthetic and surgical management, in these we extract the hopeless deciduous teeth, and the teeth with deep periodontal pockets, they are treated with flap surgery, and prosthetic rehabilitation is given to restore normal mastication. In mixed dentition, we use removal partial or complete dentures with small translucent teeth resembling the deciduous dentition, and in the edentulous patients, they are rehabilitated with conventional complete dentures, modified dentures, overdentures, implant-supported dentures, or combination of these. So dental implants, they are contraindicated in the growing patients due to risk of infraposition. So the next is dermatological management. In this, we use emollients, salicylic acid, and topical steroids. Oral retinoids such as acitretin, e-tretinate, and isotretinoin treats both the dental and cutaneous lesions. And the retinoid treatment is started at the time of eruption of successor teeth until the completion of the normal development process. If you have liked the content, please like, share, and subscribe to this channel. Thank you.